I want to thank Dean Scott and the Board of Visitors for this opportunity to share this work. My name is Andrew. I'm a critical care nurse communicator across the street at UW Health. And I'm going to talk today about improving shared decision-making in the ICU, the critical care nurse communicator program. So I'm going to start with a brief story about John. John was an 81-year-old male who was admitted to our ICU last summer after a motor vehicle accident that happened. He came to us with numerous broken bones and, most importantly, a pretty severe traumatic brain injury. John's support system included 6 children who lived across the country, and I met several of them on his first ICU day, and they shared with me that prior to this accident, John was a Vietnam veteran. He had still been working to this day as an accountant at the age of 81 and doing taxes for special clients. He was a landlord that managed various properties, and they shared with me that if he knew he was in an ICU right now, he'd be trying to sneak out the door. They also made abundantly clear that he had said in the past that he would never want to live in a nursing home and that being independent was really what was most important to him, and he valued most living independently, being able to work, spend time with his family. John's support system faced numerous difficult decisions over the course of his 21-day ICU stay about resuscitation status, about putting him on life support. And unfortunately, he couldn't be a part of these conversations. And to make things even more challenging, the children were kind of on different pages about what they thought Dad wanted. And ultimately, they made the decision at the end of his ICU course to transition to a comfort-focused approach, and he died in our ICU surrounded by his family. And unfortunately, this is not an uncommon reality in our country. 20% of Americans die in or shortly after an ICU stay. And this map shows Medicare cost data in the last 6 months of life, with darker areas being higher cost. At an average low in Grand Junction, Colorado of $8,000 spent in the last 6 months of life to a high in McAllen, Texas of $21,000. And we know also that ICU families who lose a loved one in the ICU go home with very high rates of anxiety, depression, and PTSD. So why is this happening? Well, as technology has advanced, we've been able to prolong life and also prolong death in situations where there's little hope for meaningful recovery. And families face very difficult decisions and navigate very difficult emotions as they're processing ICU care for their loved one. So in recognition of these unique challenges in the ICU, we designed an innovative approach to integrating palliative care into the ICU setting. So what we were charged with was creating a program, and we sat down with all of our attending physicians and many of our nurses to better understand what their biggest challenges were around end-of-life communication and palliative care in our ICU. And we identified the 4 following priorities. First, competing priorities. Everyone recognizes the importance of supporting families and having important goals of care conversations, but physiological needs come first, and when you're caring for a very sick patient, it's hard to have those conversations. Lack of continuity. Our attending providers change every week, and nurses work 3 days a week. So while important conversations are happening, it's hard to carry them forward, and they also fall through the cracks often. Inconsistencies in the message. Providers send different messages and different prognoses, and families get lost in the details and the big picture gets lost. And then lack of education. There's a huge emphasis in training physicians and nurses as well on diagnosing disease and treating disease, but there's no real formal education on how to lead a family meeting or how to sit down and have a difficult conversation with families. So we designed a program to address these needs. And this is what our program focuses on, 5 key areas, with a mission being to align patient, family, and clinician goals to achieve outcomes that matter most to the patient. April and I are ICU nurses. We went through some additional training and shadowed with our palliative care team and had some training in having difficult conversations with families. And in our 24-bed mixed surgical medical ICU, we focus on anywhere from 8 to 12 of those patients who are at high risk for morbidity or mortality. So we use these indicators from the literature which suggest that palliative care may be helpful to determine which patients might benefit most from our involvement, and we staff the ICU 7 days per week. This is a little schematic of the supportive interventions that we deliver throughout a patient's ICU stay. So in those patients we get involved with, within the first 24 hours, we try to have an initial visit where we try to deliver that patient from anonymity. Over 80% of these patients are incapacitated, they can't speak. And so we ask their loved ones, who is this patient as a person? What do they value most? What was their profession before this happened? Who are their support people? We address emotional symptoms with the family. As you can imagine, many patients are here unexpectedly and in very difficult circumstances, so we help them navigate that. We assess spiritual needs and get our chaplains involved where indicated. We ask them what their understanding is in the medical situation and help address any gaps there, and what their goal is for the ICU stay, and then also what they're most worried about. And one of the most impactful things we explore with them as we develop a relationship is, what has this patient said about their treatment preferences in the past? What's important to them? Have they filled out an advance directive? Then throughout the ICU stay, we check in daily with these many times surrogate decision makers to answer questions, help them navigate emotions. If we're asking family to make a decision about something, we help them process that. And then where needs are beyond our scope, we get services like chaplaincy, health psychology involved, as well as help facilitate specialty palliative care, all in an effort to really develop strong relationships with these families so we can walk beside them through their ICU stay. We also organize family meetings with a goal to have a family meeting for every patient in the ICU by ICU day 4. And there are several activities around these meetings. April, my colleague, and I organize a pre-huddle where we take all of that really helpful information we've gathered about the family, their information preferences, to this meeting before the meeting so the providers understand where they're coming from, what their questions are going to be, how they're thinking about things, so we can tailor our information to their needs. We then attend the family meeting. I've probably been in 300 family meetings in the last 2 years, so we're very aware of the best practices, what is important to cover. We're there as a supportive presence for the family, and then we make sure that that important piece of the patient's voice is at the table, because often the patients are not a part of these conversations. We then have a post-huddle with the family, and what we heard when we designed the program was that meetings are incredibly helpful, but it's a lot of information, and when you're under a lot of stress, you don't retain everything. So we create notes for them so that they can take this with them and share it with other family members who couldn't be there, or look back and reflect on how they should be thinking about things. And then in situations where we're asking families to make a decision between two options, we utilize this tool called the best case, worst case, which was designed by Dr. Gretchen Schwarzy and Dr. Toby Campbell at UW, where we have two distinct options in this situation. We've reached a point where a patient's on mechanical ventilation, and we have to decide about moving down to a tracheostomy for more long-term support versus a comfort-focused approach. And we take risk-benefit prognostic information and detail a best case, a worst case, and where on that spectrum a most likely case lies for that unique patient, to tell a story for that patient, what the attending physician prognosticates for each path. And then when patients pass away in the ICU, we help loop them into community grief resources as they transition out of the hospital. And for those that move on and survive and move on to continue their rehabilitation, we help support them through their transition, and then also encourage them and their families to have important conversations in case anything like this were to happen again. So what's the impact been? We've gathered a lot of data on this over the last 2 years and did a pre-post comparison, and we find that we're having earlier family meetings for more patients. On average, we're having that first meeting on day 3.5, which pans out to 8 meetings per week at almost 40 minutes per meeting. So it's a significant amount of time, but definitely time well spent. We've also surveyed nurses, physicians, and many of our families to gather their perceptions of the quality of communication in the ICU, quality of palliative care in the ICU, and have seen nice improvements in those areas, particularly in eliciting and respecting patient preferences and emotional support for nurses caring for dying patients, as we're many times in the trenches with them as another support person. And then moral distress, we've seen a decrease in physician and nurse moral distress, and our hypothesis is that we're having better conversations earlier in the course of a patient's care, and perhaps reducing the rate of inappropriate care at the end of life and impacting moral distress. We surveyed physicians and nurses, and many agree or strongly agree that it's been a valuable addition to the team, and that all families that we've surveyed would recommend this role to other ICU families. And then we've also looked at resource utilization, and our theory being that better conversations earlier in their patient's course for more patients may change the arc of care or the tempo of decision making and lead to earlier decisions, avoidance of future hospitalizations, and a decrease in the duration and intensity of care at the end of life, as well as patient and family suffering. And that's exactly what we've observed. We've seen in a 2-year pre-post comparison a reduction in hospital and ICU length of stay in patients who die during their hospitalization. We've also observed a 17% reduction in ICU readmissions, as well as an increased utilization of hospice at the end of life and patients spending less time in the hospital before going home with hospice. And this is hot off the press. We looked at the 2 years prior to implementation, 2 years post, and the average cost per patient in patients who pass away with us, and have seen a reduction of about $5,000 per patient, which translates to $2.34 million over the course of 2 years. And so when we look at this program in the healthcare value equation of quality over cost, we find that we've identified a huge opportunity to improve support for patients and families, to improve the quality and consistency of communication, and not only better support patients and families, but also staff, while simultaneously reducing resource utilization, all to increase healthcare value. And I'd like to thank April Buffo, who's also a graduate of this program and a current DMP student, who's my colleague who helped create the program, and then Doctors Toby Campbell and William Ellenbach, who have been our mentors through the process.